If there is any problem, then I'm going to proceed for the next case. So for next case, Dr. Usman Zia from AFIC. Is Dr. Usman Zia here? He is going to present a case for pseudo aneurysm. Dr. Usman, I'm sorry for the technical problem for the last case, but we have to proceed and finish because there is another session just after this.
Doing a fellowship in pediatric cardiology, and I am from Faisalabad Institute of Cardiology, Faisalabad. Today I am here to present a novel case of pseudo aneurysm. What is a pseudo aneurysm? A pseudo aneurysm is a false aneurysm which is only consistent of tunica adventitia and is quite fatal and can rupture at any time. So I am here to present a novel case of pseudo aneurysm here. And next slide, please. As the history of the patient was taken, there is a history of aortic valve replacement 18 months ago. And when the history was probed, the patient was reopened on the very evening due to a hematoma formation. So patient was recannulated and shipped to cardiopulmonary bypass. During that, hematoma was drained, and the cause of hematoma was RV rupture. And the RV ruptures were repaired with pericardial patch. So patient was discussed, and X-ray chest was, ECG, X-ray chest and echocardiography was performed. ECG was normal, and X-ray chest showing mediastinal widening, as you can see, mediastinal widening along with the aortic, metallic aortic valve. And echocardiography, as you can see, there is a normal functioning aortic valve prosthesis in situ with a huge cavity in front of, this is a modified view, left sternal view, with a huge swelling that is compressing the ascending aorta. I would like to take, which is, there is a huge swelling which is compressing the ascending aorta and high up in the ascending, this is a normal function aortic bioprosthesis, and high up in the ascending aorta, there is a rent, a filling defect with a to and fro movement which is communicating with the cavity, which is pseudo aneurysm. So we went to the CT chest with contrast. These are the pictorial diagrams showing the aneurysm, ascending aorta, and metallic prosthesis. So we went for the CT chest with contrast in this patient, which showed a huge pseudoaneurysm, which is arising from left internal memory artery, 9.8 to 8.5 centimeter, which was partially thrombosed and causing compression of the anterior mediastinal vessels. This CT scan was quite contradicting to our findings of echocardiographic. As you can see, we have seen that in echocardiographic, high up in the arch, in the ascending aorta, there was a rent which was communicating with the pseudoaneurysm. But here it is communicating with the lima, which was quite contraindicating. So we went for the conventional angiography in this patient. We catheterized the patient, took the patient to the cath lab, and perform an angiography. We selectively engage left internal memory artery and right internal memory artery. We came out to be normal. And we also performed an aortogram high up in the arch, which showed a rent measuring about 4.57 millimeter in diameter, which was communicating with a huge cavity. You can see there's a huge cavity which was there's a huge cavity which was compressing the anterior mediastinal vessels. As you can see, voids are also visible in this patient. So what could be the treatment options in this patient? What could be the treatment option in this patient?
Would you please repeat this, just the aortogram, please?
Okay, sir. Okay. In this, ये play नहीं हो रहा. ये play नहीं हो रहा, excuse me. This is a Lima and Rima angiogram which came out to be normal. And the second slide is in an aortogram high up in the arch. This is an innominate artery. This is an innominate artery, and there is a rent at the base of innominate artery which is communicating with a huge cavity. This is a huge cavity which is compressing the anterior mediastinal vessels. So this is what we found in CT angiography. So what could be the treatment option? I would like to engage the audience and would like to ask what could be the treatment option we can take in this patient?
Rupture is the innominate.
The rupture is just below the innominate artery, not in the innominate artery.
No, it is coming from arch also. आप उधर से देखेंगे ना.
Aortica. This is a modified view. Actually, this is a
I
modified
don't know.
view.
It's confusing a
At
little
the
bit.
base of innominate artery.
I'm getting your point. Okay.
Okay. So what could treatment option we can involve in this patient? Okay. What else? Okay. Okay. We can go for two options. We can either involve the surgical team, or we can go for minimally invasive technique, which is angiography, endovascular closure techniques, which where we can use devices, occluder devices. We can even go for coil embolization. We can go for stent grafts. These are options which we have at that time. And why we did not went for why we went for why we did not went for surgical technique? As the pseudoaneurysm is a quite fatal thing, and it was anteriorly present anteriorly in the chest, which is quite difficult to approach, as I can say, and it was huge. If it gets ruptured, it will be a dilemma and fatal, and patient can die on the table. So we went for minimally invasive technique. So patient was discussed in our surgical and medical board in the hospital, where it was decided to close his endovascularly. As the size of aneurysm was quite huge, so thrombin injection was not possible in this patient, as well as coil embolization was also not possible in this patient. If we have used a stent graft, it would have resulted in a hanging stent here in the innominate artery. It would have hanged in the ascending aorta, would have caused obstruction later on in this patient. So we went for occluder devices. So what sort of occluder devices does we have at that time? We could have used implants ASD device closure, ASD device. We could have used muscular VSD device. We could have used cribriform ASD device. We could have used multifunctional MFO, LT-MFO devices. So as the wall of aneurysm was quite fragile, we wanted to use a low profile device which takes a smaller sheath and glides over glide wire, and that can be easily delivered in this patient. So we crossed the defect with the JF4 catheter over the glide wire, and you can see we performed a angiogram of the pseudoaneurysm, which is quite huge, 11 into 11 centimeters secular. We took a novel approach and accessed the aneurysm percutaneously with a needle over the wire, and 5 French sheath was passed. Then we took the pressure of the aneurysm and the ascending aorta, which came out to be equal. We parked the glide wire in the aneurysm, and over the wire we tagged the delivery system, and through the delivery system we passed a multifunctional LT-MFO device, which is a low profile device that takes a 5 French sheath and glides over the glide wire. And Here you can see the device is being opened. The discs are being opened in the aneurysm sac. Here is the angiogram of the aneurysm. You can see there is a clot. You can clearly see there is a clot inside the, after the device closure, there is a clot formation here, which shows we have successfully occluded the duct. Here we performed a sending aortogram. You can see the aneurysm has been closed, successfully closed, and there is a minimal foaming through the device.
You need to proceed.
So here is a post angiographic echocardiography of this patient. Okay, sir. Okay, the lesion was about 5.6 millimeter. We decided to take 2 to 3 mm above the size of the aneurysm, of the neck of the aneurysm. So we took LT-MFO 10-8 device. Sorry, I forgot to mention this during my presentation. We took LT-MFO 10-8 device in this patient. I would like to.
So your time is finished, please.
This is an echocardiography which showing a device in situ. You can clearly see this is a device and there is no to and fro movement through the rent. And this is a post-procedural X-ray. As you can see, there is a decrease in the size of the swelling. Okay? The cause was ruled out to be either it was when the patient was recannulated. The second time it was recannulated, it resulted in an iatrogenic injury of the ascending aorta, which resulted in the pseudoaneurysm over the period of next 6 to 8 months. Because the size of aneurysm was quite big, we wanted to drain the blood so that the compression can be relieved. As we took the pressure of the aneurysm,
Proportion of the device also means that pseudoaneurysm is fragile, and you are going percutaneously anteriorly with this and giving you the forceful injection of the dye. So there are chances of perforation of that pseudoaneurysm at that moment.
Wait, I would like
when
to...
you are putting the device and giving injection anteriorly through putting the wire there. So just you can put the pigtail through the subclavian and from the radial, and you can took the aortogram at the above this device level or at the level of device.
As the device here and the anterior chest have quite a lot of space here, so we can perform the cutaneous intervention and can drain the...
But this pseudoaneurysm is fragile, that can be
Yes, it is
perforated.
fragile. Yes, it is fragile. But we want to decompress the swelling so that the compression that is causing that the main symptom should be resolved in this patient. We are here to decrease the agony of the patient. We are not here to close the door. We are here to decrease the agony of the patient. So we drained the swelling of this patient so that we can decrease the signs and symptoms of the patient and improve the quality of life of this patient.
Please finish the case first. Please finish the case.
That's all that I would like.
Okay. Thank you very much. Just one question from the from the panelist, and then we will proceed to the next case.
Yes, sir.
Any question from the panelist? Any comment?
First question is how you measure the size of the neck of the pseudoaneurysm, and just comment for Dr. Bashir answers. When you have already assessed the site and you are just putting the device, so there is no worry. If there is a rupture, you just close the opening, so it will just open into the chest. I think your answer should be this one.
Okay.
Something more, do you stop anticoagulant or you are...
Yes, sir, we have a patient shifted to the IV heparin and enoxaparin. As the enoxaparin was quite short at that time, so we would put the patient on the IV heparin and measured the PT-INR regularly in this patient. And started the 48 hours after the procedure, we started the warfarin in this patient.
IV heparin APTT?
Yes, sir. Yes, sir.
Okay.
Thank you very much.
Thank you very much, sir.
Okay, thanks. So, my next presenter is Dr. Jalal from PIC Lahore, and he's going to present Less is More or Face is the Music. So, let's see what is inside. Thanks, Dr. Jalal.